wait 3 to 4 more minutes. Thank you for joining us from wherever you're joining us from. We're just gonna give colleagues about 3 more minutes to join us, and then we're gonna start. So, colleagues, I'm gonna quickly take us through some housekeeping before we start the session. And you know that the UN and WHO and all its partners here today, Africa CDC, IFRC, Saving Lives and Livelihoods, the Collective Service, and Project ECHO were committed to enabling events that everyone can participate in an inclusive and respectful and even a safe environment. So as we have the conversation today, colleagues, remember to be respectful. And even when we disagree, please ensure that we disagree respectfully. Next slide. Absolutely. We're going to have interpretation in English, in Arabic, and in French. If you look at the bottom of your screen, you're going to see a globe icon like the one I have here. That's called interpretation. If you click on it, it will give you a range of the 3 languages, and you can select the one that you want to listen to and mute original audio. When you mute original audio, then you only hear the interpretation. You use the Q&A for questions regarding the topic and the presentations, only questions regarding the technical area that's being covered today. Use the chat to introduce yourself or for IT issues as you're doing already. So if you're facing any challenges joining, put it in the chat, not in the Q&A, and somebody is going to respond to you. If you look at the bottom of your screen, you're going to see a raise hand feature. During the live Q&A, I'm going to call on participants to raise their hands. Please use the raise hand feature, and then I'll give you access to speak, and then you can ask your question to any of the panelists directly. Next slide. By participating in this meeting, whether as participant or panelist, we take your attendance as permission to be recorded, and for your contributions to be recorded and shared via our various learning channels for continuous learning purposes. We will also be sharing session materials, including the session recordings. Hours actually, now it's hours following the webinar on the iEcho platform. Next slide. All of the registration data that we have collected, either to join the program on the iEcho platform or to actually join the session with the session registration questions, they're confidential and they're just for WHO. Project ECHO has relayed that information to us, and WHO keeps them confidential. So this data may be used for reports, for maps, for communication surveys, all of that. But they will also be de-identified in the process. So your data is confidential is what we're saying. Next slide. Just a quick introduction into the iEcho platform. I know that this is a new technology that we are launching for this particular training and learning team. It's very user friendly and it supports learning and program management. It allows us to share with you the materials and the recordings just a few hours after the session is over. And it allows you to actually manage the platform in different languages. Also, you have your certifications, and you can also access all of these sessions, all the materials from previous sessions, all from your phone or from your laptop. On the platform, if you navigate properly, you can see the schedule of next sessions or previous sessions. You can also discuss as sessions are going on. You can discuss with some other colleagues. They are able to access the chat of that particular program, and you're able to interact on technical content or technical opinions. So somewhat of a community of practice, if you'd allow me to say that. Also, you can use the content button over there to see the past materials and also some of the recordings of the session. At the end of the session, when you when you leave this particular session, you're gonna get a pop-up of the feedback survey. Please kindly fill it and give us your honest opinion on either the platform or the session so that it will help us to improve other sessions. And we will also be emailing you the feedback link just in case it doesn't pop up on your own browser. And you can also submit your feedback to help us improve other sessions. You can also gain access of the content used during the webinar on IQ platform itself, as I had explained earlier. So next slide. I'm now going to be taking us through the agenda of the day. Today, we're going to be having a lot of icebreakers and polls. I want to encourage that you feel them and you interact with some of the content. I'll be introducing myself. My name is Amarachi. I'm a training and learning specialist with the WHO African region. I lead the design, delivery, and coordination of learning systems for health emergency preparedness and response. Shortly after this, while we're transitioning to the next presentation, we're going to have an icebreaker. Like I said, I encourage you to interact with that. Uh, After that, we're going to have introduction to the series. It's going to be some setting the scene and objectives, and this is going to be done by Dr. Danielle Dormesand from IFRC. She is currently the health delegate and knowledge and learning coordinator for the Saving Lives and Livelihoods program of the IFRC African region. She has extensive cross-cultural experience throughout the Caribbean, Latin America, and the African region. Shortly after that, we're also going to have a poll, and we're going to have introduction to fundamentals of risk communication and community engagement by Aminata Grace Colby, who is also from the WHO Afro. She's the technical officer of health promotion and community engagement with the WHO African region. She supports countries and empowers individuals and communities to make healthy choices. She has extensive experience across the African region, including Sierra Leone, Sudan, Uganda, and with the WHO, Ministry of Health, Oxfam GB, and Helen Keller International. And then we're going to have the first Q&A session. This session is going to be moderated by Dr. Daniel. And then shortly after that, we're going to have an overview of SBCC theory and models by Mary Inyikuri from the Africa CDC. She's an anthropologist with 20 years of experience working at the interface of communities and public health at the global, regional, and national levels. Mary currently leads the health promotion unit within the Division of Community Health Systems and Health Promotion at Africa CDC. She's the RCCE pillar lead for the Saving Lives and Livelihoods program, and she holds a PhD in public health. And shortly after that, we're also going to have the Q&A session too, and this will also be moderated by Dr. Daniel. We're then going to have the role of RCCE and community feedback mechanisms in pandemic and epidemic response, including integrated immunization program by Yves Stefan of IFRC. And he empowers communities to navigate health crises through effective risk communication and engagement. His work includes direct support for pandemic responses like COVID-19, like cholera, like the mpox, and he focuses on integrating immunization programs and addressing vaccine hesitancy through community feedback mechanisms. And then shortly after that, we're going to have Dr. Ilyasa Mwangi, and May Nafonti, who will be taking us through understanding RCCE through country experience, case study, country, yeah, we're going to have a case study on country experiences for epidemic response, including vaccine introduction. Uh, and I think we're going to be using cholera as a case study, and Comoros is one of our countries that's going to be sharing their experience with us. And then we're going to have an interactive Q&A session with the panel. As I had said before, you raise your hand and you're going to have the opportunity to interact directly with the panelists and or the moderator of the Q&A session. And after that, we're going to close for the day. A short introduction of Dr. Ilyasa. He is currently the Community Engagement and Accountability Officer for the Saving Lives and Livelihood project with IFRC. And he's also a trainer for community health workers and volunteers engaged in the project. He has extensive experience supporting community engagement during emergencies, and most recently, during the cholera outbreak in Ajuan, where he worked alongside IFRC and trained local teams in risk communication and community engagement for the cholera response. Ladies and gentlemen, I have just introduced the entire panel to you today, and may we begin. And I wish you a productive session. So we're going to now have a quick icebreaker or a poll up on the screen. Um, Aditi, over to you. Can we pull up the poll? I encourage colleagues to take 3 to 5 minutes to respond to the poll. The question is coming up, and then we can proceed. Colleagues, please use the react button to confirm if you can see it on your screen exactly. So we've started to have some responses. Absolutely. Great. Thank you so much. All right. We have 35 responses. We have about 2 minutes to go, and then we can take the poll down. Colleagues, I encourage you to interact with the poll while it is still up. We have 2 minutes to go. And while that is happening, may I take the time to acknowledge the presence of some of the colleagues who have introduced themselves in the chat. We have Tambi Elvis, who is an epidemiologist and an immunization specialist. Tambi didn't tell us where he's joining us from. Thank you for joining us, Tambi. We have Nathan Camille from Central Africa, and we have Bisombolo from DRC. We have about a minute on the poll before we hand over to Dr. Daniel. Colleagues, we have 62 responses. Good. We have Ahmad Baba from Nigeria. Thank you for joining us. We have Mohandas from India. Thank you for joining us. Okay. Yes. Aditi, may we end the poll and project the result while we're having our Daniel slides up. All right. Now, may I hand over to Dr. Daniel Dormisan from the IFRC African Regional Office. Dr. Daniel, over to you.
Thank you very much, Amarachi, and good morning or good afternoon or good evening to everyone, wherever you may be seated and listening from. It's a true pleasure and honor for me to be here today and set the scene of sorts for this very first of a webinar series. So acknowledging everyone attending, acknowledging our esteemed speakers, our agency representatives, partners, our colleagues and panelists here today, our attendees, you all that have been introducing yourselves in the chat as well. So all protocol observed, I would like to start us off on this RCCE, so risk communication, community engagement webinar series, first by giving a little bit of context as to why another RCCE webinar, why now? Why is it important? And effectively, we've had a long continuity of webinars. For those who have been part of the first series launched by the IMST, where we delved into pandemic preparedness and response related content, but there was such a high interest for the risk communication and community engagement webinar series that we sought out to address the pending questions and delve more into the RCCE topic. And it comes in complementarity with the Saving Lives and Livelihood program, which IFRC, Africa CDC, and in partnership with MasterCard Foundation have launched to cover and fill some of the gaps along vaccine coverage, especially among the adult population, among the community health workers and workforce. So all of that interest and from different partners and stakeholders that Marachi has mentioned, we have launched this webinar series that will progress into a full training series. So today we will look at the fundamentals, and really we will look at why RCCE is important as key evidence. RCCE, based on evidence, is important to impact effective public health response and recovery, including immunization programming. And next, then, we will look at the specific objectives which for the series. So this is, like I mentioned, the launch of the series. So we would have, in terms of the series, and you are here, so you have likely fulfilled the proper steps to enroll into the full series. So the full series objectives really is looking at strengthening our risk communication and community engagement in either epidemic or pandemic preparedness, response, or recovery to outbreak-prone diseases. Also, we look at fostering knowledge of RCCE for social behavioral change, looking at the fundamentals, the principles, the strategies, and best practices. And that would include among responses, looking at also immunization programming as well among our case studies, etc. This also series aims to ensure that the participants or attendees have the fundamental knowledge of RCCE to then progress to the full training program. And now, next, we would look at the specific objectives for today, which would cover then, as you may see, ensuring that the participants or the attendees, and we say participants, so your active participation and question is expected. So ensuring that the participants acquire all the basic knowledge, the fundamental knowledge of RCCE and social behavioral change, or SBC, as part of said epidemic, pandemic preparedness, response, and recovery. Specific objectives would include increased knowledge to align understanding on social behavioral change models, and also provide case examples as mentioned by Amarachi along epidemic, pandemic preparedness and response programs. So and that aligns with our agenda for today that was explained earlier. So just a few key highlights as well before speakers launch into their presentations. Next, please. And give a little bit more context. So next, we would look at some key items we would want to flag, and as you listen into our speakers, our keynote speakers and panelists today, is looking at risk communication and community engagement as a key piece of readiness and response, making sure that the communities remain engaged, informed. I'm not sure if you're still seeing me. My lighting has gone a little bit, but making sure that our communities are engaged and informed and empowered. That's during, before, and after any health emergency or response program. That is meant to foster resilience. We look at you will hear from RCCE as a key piece of health regulations program, and you will hear from that as well from Dr. Kobe. You would also look at underlining and looking at how the RCCE really is a community-led, community-centered strategy with its corresponding approaches and tools. Really, RCCE is a game changer for even immunization program. RCC has proven very critical in adult immunization, for instance, addressing misinformation, identifying behaviors and barriers, and we'll delve into more of that as the session progresses. We will look at moving from the theoretical aspects of RCCE to more practice and practical examples as well for your day-to-day work, and we hope it will be of use from operations to policy work. Really, we would look at having key highlights around listening and community feedback as key part of our RCCE components and programs. And there's more to be said on that throughout the session. Again, we would have RCCE highlighted as, again, important and critical for all the work that we do in country or cross-border or as part of cross-sector collaboration under the wider One Health umbrella, for instance. Really, we're moving away from simple beneficiaries or recipients and having communities having full participation ownership into the respective programs. So really, as the takeaway message, as I give it up, I give it to the floor to our speakers. My final parting words would be on really RCCE is a cornerstone of public health programming. Hoping that you will enjoy our program today. Have a good session and all the best. Over to you, Amarachi, to introduce our next panel.
Thank you, Danielle. That was really timely. We were running out of time a bit. Okay, do we have another poll to put up at this time, or do we move on to the next session, Aditi? I believe yes, great. So colleagues, please take some time to interact with the poll up on your screen. I see that we have colleagues, please use the react button to just confirm that you can see the poll on your screen. Could you please confirm for me if you can see? Oh, thank you. We're beginning to receive some responses, and we have about 2 minutes for this. While that is going on, I am told that some of the colleagues are struggling with interpretation. Colleagues, please look at the bottom of your screen. You're going to see a globe icon. It's the icon of a globe, and under there is written interpretation. Please click on it and select the language that you'd prefer there. While that is going on, may I take the minute that we have for the polls to acknowledge some of the colleagues who have joined us. I think we have Helen Kariuki, IFRC Nairobi. Thank you for joining us. We have Joseph from Togo. Thank you for joining us. We have Thomas Bolochi from Comoros. Thank you for joining us. And Ricky from Zambia. Thank you for joining us. We have Diana Gatwiri from Kenyatta University Teaching and Research Hospital. Thank you for joining us. Oliver Ja from Monrovia, Liberia. Thank you for joining us. I'm afraid we don't have more time for the polls. May we launch the results now, as we have Aminata Grace Kobe from the WHO African region come up for her presentation, and she will be doing the introduction to fundamentals of risk communication and community engagement. Aminata, if you're ready, over to you.
Thank you very much, Daniel and Amarachi, for proceeding with the presentations. I want to say good afternoon, good morning, good evening, wherever you're connecting from, and to say thank you for joining. You're welcome to this session. Next slide, please. So at the end of the session, I would be able to share with you the definition of risk communication, And we'll be able to discuss why it's important and needful during, before, and after an emergency. And you'll be able to list 5 domains in risk communication. Next slide. Risk communication, I'm sure we all joined this session because it's a very important area of responding to public health events. The definition is the real-time exchange of information or advice between experts and those that are being affected by a public health event. It is important for us to know that risk communication involves information and engagement with those that are affected for them to be able to take decision and action. So until we have decision made and actions being taken to protect themselves, their loved ones from a public health event, we have not yet completed risk communication. So it's very critical for us not only to pass on the information, but to ensure that they are able to take decisions and to take actions to protect themselves, their families against the public health hazard that they are facing. Next slide. As I said previously, everyone at risk is able to take the informed decision to mitigate the effects of the threat. So it does not only restrict, it's not only restricted to diseases, but also to public health events like fire accidents. We have a lot of environmental hazards, floods in our region. So all of these, you can use risk communication so that people know what to do to protect themselves and to prevent further diseases or to prevent themselves from further ill. Next slide. Risk communication uses a mix of communication and engagement strategies and tactics. It includes radio discussions, social media engagement, campaigns, health promotion, stakeholders engagement, social mobilization, and community engagement. Next slide. In risk communication, I'm using as a reference the 2005 IHR International Health Regulation and also the second edition of the Joint Evaluation Tool as a reference. It has 5 areas we focus on. The first one is risk communication systems for emergencies. I'll be able to go through all of them one by one. The second is internal and partner coordination. For emergencies, you have public communication, community engagement, perception risky behaviors, and misinformation. We'll start with the first one, which deals with the system. Next slide. Risk communication systems for emergencies. As you are all aware, when there are emergencies, a lot of partners come in to support risk communication and community engagement. And if there is no system to be able to manage to coordinate this among the partners, then it's a challenge. So there are several suggestions that are being put forward to be able to communicate and have a very good system of risk communication. Next slide, please. The first and very important aspect is to have a system that does not only look at risk communication itself, but it is multi-sectoral and deals with other partners and other sectors of the response system. It includes the surveillance, case management. There should be a system wherein we communicate with them and also with other sectors that are responding to the particular public health events we are dealing with. There also needs to be a plan not only that is in the cupboard, but a plan that has been agreed upon by all the partners and that has already been tested. So until it is being tested and agreed upon, then you cannot call it a national plan or a plan of a country. So all these processes needs to take place for us to really see that this is a national or subnational risk communication plan. And there should be a system wherein there are adequate staff to respond, to really implement the risk communication, not only staffing, but also financial support. And as we all know, those of us who are supporting risk communication, this is one of the areas where we have a lot of challenges. We realize that other areas are really being supported financially, but risk communication is one of the areas that is really challenged with both staffing and financial support. Next slide. The second system is engagement with communities, engagement with affected communities and communicating with them. It is key, as we are aware that for risk communication, we propose a lot of strategies, actions that should take place to break chains of infection. And breaking the chain of infection happens at community level, at the house level, at the village level. And if you are not engaging these communities, it's difficult for actions to take place. Next slide, please. For this area of risk communication, communities should be included even as you prepare and response to the particular outbreak. Without involving communities, it's difficult for them to own the response. So it is key for communities to not only be involved in preparedness, but also be involved throughout the response system and even with the evaluation of the risk communication aspect of the outbreak. Communities should be mapped before an emergency. And this, I know we don't do a lot, but it is very critical for communities to be mapped before, but the map needs to be updated based on the specific emergency that is being dealt with. There should be an ability to surge community, to increase community activities during the emergency. So even as we are planning, we should think if the cases increase, what are we going to do so that we can be able to increase our activities within the community based on the situation at hand? And we should be able to manage community engagement, social science data, and incident management system to be able to review our actions and plan further actions with the involvement of communities. Next slide, please. For public communication, I know this is one, when evaluations are done in country, this is one of the strong areas that countries do very well in, and they use a lot of other means of talking with communities, including radio, social media. Now, if we can go to the next slide, please. It is important for us to use diverse set of strategic, mass and social media outlets, particularly based on the region or the specific communities that are being involved. If you're dealing with a community that does not have access to social media, it's not wise for you to go and use social media to disseminate information to that specific community. Partnering with media has worked very well, partnering with media houses to disseminate information to the community, using the media and the target audience uses regularly has yielded a lot of results, and the ability to surge and respond in consistent and continuous fashion. If we are using radio discussion, we should have the ability, when people ask questions, to be able to go back to them and give them feedback. Once you are being consistent in using social media or any other media outlet, you realize that the engagement with the community and the involvement with the community increases a lot. Next slide, please. Perception and risky behaviors and misinformation. Definitely, this is an area that is new, but we really need to improve on how we respond to this. The issues of rumors and misinformation has been heightened during the past few outbreaks that we have in the region. However, the more we engage with communities, as has been discussed in the previous slide, the better we are with reducing misinformation and perceptions. Next slide, please. Addressing perceptions and risky behaviors, there are several mechanisms that have been used and have been shown to work. There should be a mechanism in place to systematically gather information and perception from the public and use this information to upgrade our program, to reinvent our programs, our strategies to reach out to the communities. What has been used, you have media monitoring, including social media hotlines, have been used in a number of countries, and also community engagement. Changing communication strategy to address perceptions is very important, including risky behaviors. So we are not just only collecting this information, we are collecting this information from the public in order for us to change our programming, in order for us to review and respond to the needs. As a reminder of what risk communication is engaging with communities real time so that we are able to change their behaviors and they are able to break the chains of infection or protect themselves and their families. Next slide. Internal and partner coordination. This is very important as we have a number of partners that are working in risk communication and community engagement areas. It is very important for us to be singing from the same hymn sheet, or for us not to have different messages from different partners. So it is critical for us to have one plan, a coordination system wherein all of our messages speak to each other and we don't bring much confusion to the public and the communities we are responding in. Next slide, please. There should be an internal communications team that communicates all the other partners and every activities that are being done by partners. There should be regular coordination meetings so that we are working in all voices during, after, and before an emergency. There should be an agreement on the communication protocols that should be used, which agency should speak about which threat, and how you coordinate each other to respond to the public. Which agency speaks first, which agency speaks second, all that needs to be planned during the internal and partner coordination system. Next slide. Thank you very much for listening. I'll be waiting to hear your questions. Over to you.
Thank you so much, Aminata. That was very brief and timely. Aminata tried to do justice to the IHR part and the JEE, and she tried to connect how cross-cutting RCCE is for all of this important activities that we have in health emergency preparedness and response. Unfortunately, these are also very large areas that require days of training, and she tried to do this in about 3 to 5 minutes, and I think that that was really impressive. Colleagues, just to also add that we have the chat feature and also the Q&A. Should you have more questions even after this Q&A session that we're going into, please put it in the Q&A, and the panelists are going to go in there and answer some of your questions. Right now, I'm going to hand over very quickly to Dr. Danielle Dormisa, who is going to moderate a Q&A session. So should you have any questions for the first two presentations that have just happened, you might want to put up your hand and she will give you access to speak, and she's going to assist with assigning this to the panelists. Panelists on the call, before I hand over to Dr. Danielle, please may you turn on your videos. I have a request from the IT team and they are trying to do some IT checks. Please turn on your videos while the next session is going on so that they can quickly do that. Dr. Danielle, over to you.
Thank you so much, Amarachi, and thank you, Dr. Kobe, for your insightful presentation, really rich. And as Amarachi said, we could delve longer into these topics, but you were very, very focused on explaining how the RCCE ties into the international health regulation and the JEE, and part of even the assessment mechanisms and the key pillars that you've presented, the 5 pillars you've presented. Really, we would love to see questions in the chat. We have a few Q&A questions and answer, sorry, questions in the chat. So we would delve into those. Let's see. First, 2 sets of questions for you, Dr. Kobe. One is a remark. Thank you for the presentation. It was important to mention One Health approach, considering its critical role during the recent GE. Yes, I think we've mentioned that in very briefly, but it is really something we're keen to tie more directly into as we progress into our future sessions. And the next comment we have from Madame Garnier. Was mentioning, can you please clarify strategy 1? I'm not sure if you got that question, or do we need to ask Madame Gardner to clarify? Dr. Kobe, do you need more clarification on the question? So I'm translating from
No, I'm fine. I'm fine.
Okay.
Yes. Thank you very much for the questions. Yes, with regards to One Health system, as I was presenting, I spoke about One Health system. I did not speak about One Health system, but I spoke about multi-sectorial coordination. As you may be aware, when we talk about risk communication on in a broader sense, health promotion, we need all sectors to be on board to be able to respond to public health events. As for actions to be taken at community level, we need an enabling environment, and this enabling environment is being provided by all other sectors. But specifically coming to the One Health approach, an example is the mpox response. We have to work with people not only from the health sector, but we also need to look at the people from the animal sectors. And if the evidence show that a lot of infection starts from the animal and moves on to humans. So definitely, if we really need to do a very good job, we need to work with colleagues from other sectors, especially with the animal sectors. And for most countries, the RCCE Coordination Committee also involves people from the animal sector. With regards to the second question, we deal with One Health, with the health system, it is critical that we have a plan as a country, not only a plan, but a plan that is multi-sectorial, involves all sectors and all the partners that are doing risk communication in the country, and also to have that plan being tested. So if it's been tested in a situation where you expect, let's say for a cholera situation, then you will know that yes, what we have planned is feasible. If it's not feasible, then we can go back and review the plan, refine our plan to meet the specific challenges that was faced whilst testing the plan. I hope I've answered your questions.
Thank you, Dr. Kobe. Maybe you have time for 2 more questions, and I'll also love to chime in. There are 2 questions, and then we'll circle back to some of these in later sessions. So, for instance, the questions on vaccine hesitancy, we'll have more sessions after Dr. Mary's and Eve's presentations. We'll delve into vaccine hesitancy later on, so we can pause on these questions for now. And then there's a question, Dr. Kobe, if you want to start us off on, is there a link between RCC and health supply chain in emergencies? That's a question from a colleague in Nigeria. And there's also another question on, do we have RCCE for antimicrobial resistance interventions? Interesting. Over to you, Dr. Kobe.
Thank you very much. These are very good questions. The first one has to do with supply chain. risk communication as part of the entire response system has to be speaking to each other. As a supply chain, I'll take an example of vaccine. I'll also take as an example of, let's say, chlorine for outbreak of cholera. And if you're working in communities and talking to communities, training them on how to disinfect water, to make water safe for consumption, and the supplies to this community is not available, it causes a lot of problems. So there's an issue of credibility, there's an issue of building trust with these communities if the RCCE team does not work, not only with the supply chain, but with all other aspects of the response team. So it has to be an integrated system wherein we speak with each other, we give each other feedback, and we support each other. So that whilst we are talking to communities about treatment of water or about bed nets, we are sure that we are not only raising their hopes, but that the supplies will be available, or else we need to discuss with the communities other means of responding to these issues. That is one. Secondly, there's an issue of, what was the next question?
Yes, the linkage between RCCE and
Yes,
antimicrobial
antimicrobial
resistance.
resistance. Risk communication, it's the center of all responses. Irrespective of the response, the key for us as risk communicators is for us to be able to understand what are we going to communicate with the public, what are the issues, where is the community standing, so that we don't discuss with communities about what they already know, about what they are already convinced about. We want to know where they are, whatever the issues, antimicrobial resistance, antimicrobial issues, or any other health issues. Risk communication and risk communicators are able to deal with those issues.
Thank you, Dr. Kobe. And really important stressing, you had mentioned that it's RCC is a multi-hazard and cross-cutting to a lot of the interventions. So I believe you've answered both questions. I do understand our colleagues from even the pharmacovigilance sector do use key pillars of RCCE as part of their wider pharmacovigilance or vigilance programs, vaccines, medicines, etc. So thank you for this. Amarachi, do we have time for one more quick question?
Absolutely not. I was just texting you that we needed to wrap up and move on.
Sure.
Apologies.
Then we'll circle back because Dr. Kobe can answer the questions on standardized reporting for RCC in the chat. Thank you, everyone. And please be sure to use the Q&A button for your questions. We'll have a next section of Q&A and a full panel discussion later. So thank you and keep your questions coming. We'll make our best. We'll do our best to address all of them by the sessions end. Thank you, everyone. Over to you, Marashi.
Thank you, Danielle. Thank you, Aminata. That was really, really timely and very helpful. Um, Unfortunately, we will not be able to take a poll at this time because I'm going to take some time to acknowledge an RCCA expert that's also on the call with us, Deogracias Kakule Siku. He's a risk communication and community engagement and meal expert with the WHO African region. Currently, he works with Aminata and he's worked with us in the Nairobi and Dakar hubs. Uh, Previously, he's also worked with WHO HQ supporting several emergencies, including COVID, including Ebola outbreaks, Marburg, Mpox, cholera, and he's on the call. And he's also able to support with answering some of these questions, Danielle, for future Q&A sessions. Currently, Deo is deployed in DRC supporting the country office and the Continental Mpox IMST. So for colleagues who are asking really precise questions to Ebola and Mpox, he's able to give you some context to as it concerns that. So we're going to move on now to the next session very quickly. We're a few minutes over time. We're going to be inviting Mary Yikuri from Africa CDC, who is going to be doing an overview of SBCC theory and models. Over to you, Dr. Mary.
Good afternoon, colleagues. Good morning, colleagues. I am not Dr. Mary. She had to attend to some emergency. My name is Pedamoyo Magaya. I'll be standing in for Dr. Mary. I'm the Principal RCCE Advocacy and Social Mobilization Coordinator with Africa CDC. I'll be happy to take you through your slides. We can move. So the learning objectives of this slideshow is to introduce the participants to the basic SBCC definitions and to explain to the participants what hesitancy is and its causes using the 5C model, and to give participants an overview of SBCC theories and models. Move on. So we'll start with a bit of our definitions. Our first definition is on behavior, which is an action or reaction under specific circumstances, the way a person behaves towards other people, the aggregate of responses or reactions or movements made by an organism in any situation. So from behavior, we talk about behavior change communication, which is a strategy to promote positive behavior change through targeted communication efforts. The goal for behavior change communication normally is to ensure that we are empowering individuals and communities with information and motivation to make informed decisions and sustain positive behavior change. This mostly applies when we're dealing with RCC and SBC interventions. Moving on. And hesitancy. So hesitancy is a feeling of diffidence and indecision about doing something when one person is uncertain or reluctant to make a decision, be it about a health-seeking behavior. Somebody has to ask himself, do I want to get vaccinated or not? So this is what we refer to when we talk about hesitancy. There are factors that contribute to hesitance, as some have already been mentioned by the previous speaker when she talked about misinformation. There are issues around a lack of trust that contribute to why people do not come forward for vaccination, why sometimes we have a low coverage in terms of immunization. There are also some personal and cultural beliefs that impede people to come and access services, and also sometimes past experiences. Maybe the last time that I got vaccinated, I got sick. So when there's a new vaccine, do I want to come through? So all these are centered around hesitancy, and there are critical issues that need to be addressed whenever we're coming up with interventions for RCC and SBC. Let's move on. The other definition we'll talk about is theory. What is theory? So theory is a set of ideas, principles, or hypotheses that explain and describe a particular phenomenon. So, or aspects of the world. It is based on observations, data, experiments collected to support its validity. So in brief, a theory explains how something works and why it works. Moving on. So why do we use theory? We use theories to help us understand many aspects of the environment. We need to make sense of observations, we need to predict outcomes, and we need to guide practices. We use theories to predict behavior such as symptoms of disease. We need theories whenever we're doing fundamental research, because every work that we do in RCC and SBC should be evidence-based. And when we want to be putting resources where interventions work, we also need to consider the theoretical frameworks. Moving on. So we have the 5C model of hesitancy, which is the confidence, complacency, constraints, risk calculation, and collective responsibility. When we are looking at confidence, we are looking at the trust in the effectiveness and safety of the behavior that we want to promote. We want to address our vaccine intake. How do we tailor make our messages to build that trust within people so that we can counter the hesitancy that exists in communities? We talk of complacency. Complacency, if people do not see this mpox as a threat, they will not be able to act. So how do we tailor make our messages to ensure that we promote that positive health-seeking behavior among people? Constraints, what are the structural, psychological, political, social, cultural constraints that will stop someone from accessing health services? All these are things that we need to put into consideration when we're coming up with our interventions or when we're coming up with our activities that we want to promote a positive health-seeking behavior, to promote a sustained health-seeking behavior in the communities. The same with risk calculation, which refers to the comparison of personal health risks of infection versus vaccination, and then the collective responsibility, where we're looking at the desire and willingness to become vaccinated, not to protect myself, but to protect the community as a whole. Thank you. Next slide, please. So I'll go on to talk about the SBC overview. So over the years, we have realized that there are so many models that have been created. We have so many theories that have also emerged, and all these, they help us understand why and how people change their behavior. I think what is very critical to note is there is no single model or theory that can fully represent the work that we do. Hence, the need for us to triangulate the different theories to see what really applies to the intervention that we're working on, what really applies to the ultimate goal that we want to reach. Oh, next. So I'm just going to talk through some of the theories. I know we have more than 82 theories that have been propelled, but because of time, I think we'll just talk about the big guns that we normally use in our RCC and SBC interventions. So we have two types of behavioral theories. We have the behavioral prediction and the theories of behavior change. So when you talk about the predictive theories, we are looking at how to address why people change their behavior, what prompts people to perform or not to perform a certain health-related behavior. And now when we're also looking at the behavior change theories, we want to explain how people change the behavior, the stages that individuals go through as they change their behavior. As we all know in the work that we do in SBC, behavior change is not static and it's not one size fits all. There are stages that people have to go through. They might make progress and they might come back. So those are the things that we need to understand as we tailor make our interventions. Moving on. So we do have different categories of level of change. We have change that happens at the individual level. We have change that happens at interpersonal level and change that happens at community level. And when we are looking at these levels, we are also looking at the personal behaviors at individual level, the social networks, how they influence interpersonal behavior, and the community, where we come from, how does the community play a role in influencing behavior change? Next. So now looking at the theories in brief, at individual level, we have the common health belief model, we have the reasoned action, and we have the stages of change. All these theories, they put an emphasis in planned behavior, in rational decision-making processes. At interpersonal level, we normally speak about the social learning theory, the popular Bandura theory, where we're looking at the social comparison, learning from role models, self-efficacy. You find that sometimes when we do our campaigns, we bring the influencers, we bring role models. Why? Because we know that if we put a role model, people will be able to listen and people will be able to say, yes, I'm going to get vaccinated because my role model went ahead and get vaccinated. And then at community level, we have the theory of gender and power, we have the division of innovation and the ecological models. In these, we are looking at how the divisions of power, labor, play a critical role in influencing behavior change. Next slide. So application to behavior change, when you look at the health belief model. So here we're saying people form behaviors based on perceptions. One can ask himself or herself, how severe is the illness? If I do not perceive it as severe, will I go and seek treatment? No. How about I try alternative medicines? You can ask a question, how likely could I get it? You said it's mpox. It's spread through contact. I'm not in contact with anybody. So should I be scared? What do I benefit from trying to prevent it? And how effective is the new behavior? So there are many questions that are asked by individuals. And when we are now making our interventions, these are the critical questions that we also need to address so that we do not leave anyone behind when we come up with interventions to respond to RCC, to respond to outbreak response, even just for routine behavior work that we'll be working on. Then the theory of reasoned action. So people make decisions by weighing advantages and disadvantages before deciding to practice it. If I get vaccinated, what's in it for me? If I don't get vaccinated, will I die? I've had mpox before. They say it has been there since time immemorial. I never got vaccinated. So should I go ahead? You see, so these are the things that we also take into consideration, and these are the things that we need to address as we come up with our interventions. Moving on. So we also look at the trans-theoretical model of change. Like I said, behavior change is not a one-way street. We know we want to move from a position where someone does not want to seek health services to a point where they will say, yes, I have done it. But you find that it's not linear. So how do we address each step? Someone may decide, okay, tomorrow I'm going to get vaccinated, and then they change their mind. How do we address that so that we sustain that need for the person to get to the last step? And when they do get to the last step, how do we sustain that positive health-seeking behavior was not just a once-off event? It should always happen. COVID came and went. We have mpox right now. So how do we sustain that? If ever, God forbid, we have a next outbreak, people will come through and get vaccinated the same they came through for COVID. Next slide. So we also have the theory of gender and power, where we realize that there are power dynamics that can happen in societies that can also influence our behavior change. We have the sexual division of labor, we have the sexual division of power, we have the structure of catesis. How then do we make sure that as we come up with our interventions and strategies, we make sure that we create that balance so that no one is left behind? We also have the social learning theory, which proposed that learning occurs through observation, imitation, and modeling, and is influenced by factors such as attention, motivation, attitudes, and emotions. There are so many theories that we can talk about, but I know because of time, we cannot go through each and every one of them. Next slide, please. So yeah, we have the common ecological theory, we have the diffusion of innovation, where we are moving from innovators, the early adopters, early majority, late majority, and laggards. So this is one of the most critical theories that we have to work with. Why? Because at every stage, when we are coming up with interventions, we are coming up with messaging. We should never practice a one-size-fits-all, because we are dealing with different communities, we're dealing with different reactions to communities. So if we have innovators, what messages can we tailor-make to suit them? We have the early adapters. How can we make sure that we sustain? We have the laggards. These are the most difficult, but at the end of the day, we want everybody to get vaccinated. We want everybody to access health services. So how do we tailor-make our interventions? How do we tailor-make our strategies to ensure that at every stage we have messages, we have communication that addresses the needs, and at the end, we all have people that are accessing our health services. Moving on. Next slide. So, question is, like I mentioned earlier, if somebody is to ask you which theory or model should be used, like I said, we do not have a one-size-fits-all. We can borrow and learn depending on the situation, depending on the context, depending on the target market that we are targeting, and also depending on the outbreak that we are responding to. So there's no one-size-fits-all, but we can borrow from the different theories to ensure that we come up with a strong strategy to respond to any outbreak, to respond to any emergencies. Next slide, please. So I think I'm about to wrap up. So in social behavior change communication, how is our work supposed to be? So SBC should be research-based. If you want to make an impact, make sure you have done your research. With no research, you create campaigns that do not address the needs of the communities that you want to serve. So research is very important in SBC communication. Research is very important in RCC. Client-based, you want to make a change to the client. If you do not involve the client, and if you do not have the client in mind, you will come up with an intervention that will not make any impact. you will come up with an intervention that will have negative outcomes. So all our interventions should be client-based and benefit-oriented. I think sometimes we have moved from a part where we have instilled fear so much in people. This time, we are selling the benefits. Get vaccinated. Why? You are going to protect yourself. You are going to protect your family. It is for your own good. You will not get this disease. So when we are tailor-making our messages, this is where we're now moving to benefit orientation. Service linked. Okay, yes, we have mpox. We are asking you to go and get vaccinated. Where do you get the service? So our message has to be wholesome to make sure that we are addressing the client, we are packaging the benefits that come with it, and we're even referring them to the services where they can go and access, because you do not want to create demand where the supply is not there. Let's balance creating the demand, knowing that the service is readily available for people. And our messaging, our interventions should be professionally developed. That way, people can have trust in the healthcare system. Education focus, and now we're talking about sustainability. Our intervention should just not be a one-off event. How do we sustain in the future outbreaks that are going to come? How do we sustain, and what resources are there for us to be able to make sure that these interventions that we are going to be implementing are sustainable? Next slide, please. So I think this is just hesitancy is a continuum. We will share the slide so people can just go through the circles. Next slide, please. You see, this was created by a scholar. In case people may want to know more, these are some of the references, especially remember when I'm talking about theory, three theories were proposed by some scholars. So yeah, some of the references are for future use. I think I've come to the end of the presentation. Thank you for listening.
Thank you so much, Baida Moya. This was a very, very informative presentation. So informative that you broke down the theories of change for social behavior change so simply. I hope that colleagues enjoyed the presentation and I hope that they understood. Right now, we're going to go into the Q&A, and I'm going to be handing over to Danielle Dormisan. But colleagues, this was such an informative session. Please put like one takeaway that you took from her presentation, one thing that she said that really stuck with you throughout our presentation. Just before we go into the poll, I'm gonna hand over to Danielle Dormisan to handle the Q&A for this session. Danielle, you have about 5 minutes, so I suggest you take fewer questions so that you can have a good conversation on the one that you take. Over to you, Daniel.
Thank you so much, Amarachi. I think some of the questions were addressed well, I think, from our previous speaker, and they were actually addressed by our by Damoyo. Thank you for the presentation from Damoyo and Dr. Mary. Can you please put in the chat if you have additional questions? In the meantime, maybe it's slightly outside the scope, but I do know you work extensively on this, Padamoyo, so I'll put you on the spot. There's a question on, is there a difference between an RCCE strategy and an SBC strategy? Would you want to take this one, or who wants to jump in?
Okay, I'll just take it briefly, but I'll also ask my colleagues if they will be having anything to add. So normally when we're talking of an RCC strategy, a risk communication community emergency, is normally when we are responding to outbreaks. This is now, there's an outbreak that has happened, what do we need to do? And when we talk of SBC, SBC is sustained behavior change. We are doing vaccination, we are doing immunization. How do we sustain that behavior over time? So in brief, RCC strategy is now there's a problem we need to address. SBC, how do we make sure that we sustain this over the time? Thank you.
Thank you very much, Padamoyo. Dr. Kobe, did you want to add anything? I think that was a very clear explanation, though we do hope that there will be a bridge between, especially when you reach your recovery phase, you will start to change from the epidemic response to more a longer term view and sustained change, as Padamoyo mentioned. And I see both speakers have talked about the importance of evidence, research, and data. That's also a key component. So I don't see any new. Let me check the chat because we have maybe 1 minute to pick one other question on social behavioral change. Okay, that's an interesting question we have from Philippe. I'm not sure I'm pronouncing correctly. So many theories. Is there a guidance criteria for contextualizing applications? Criteria for contextualizing application. Over to you, Padamoyo.
Sorry, could you come?
Yes, so you've mentioned there is not a single theory. I think you've mentioned a number like 80 plus, 82. So, but there are question in the chat from Philippe Ngere. I hope I'm pronouncing correctly. He says or asks, among those many theories, is there a guidance or criteria for contextualizing application? And I'm guessing the undertone of the question is, how do you choose one to maybe further your part of your presentation that you've mentioned briefly?
Okay, it's fine. So like I said, especially if it's during the outbreak responses, maybe there's a certain community that is resisting to health-seeking behavior. So what do we do? Is it individuals that are influencing it? Is it the collective cultural practices? So there are so many considerations that you have to make. Check if, remember what we said, that we need to have some evidence. So you can do your assessment to find out, is it the individual? Is it at individual level? Is it at family level? Is it at community level? So if you find the results, you then see the theories that can be applied to it. Is it the health behavior, health belief model, or is it the division of innovation? So first do your research, see where the gaps lie, and then you can find theories that can then be able to be used to address such gaps. And like I said, sometimes it may not be one theory. There can be different theories that you can apply to make sure that at the end of it, what is it that you want to achieve? You want people to come and seek your services. So how are we going to do it? Thank you.
Thank you very much, Padamoyo. Over back to you, Amarachi, for the poll and next speaker.
Thank you. Thank you so much. That was a very brief Q&A session. I'm waiting to read your takeaway from that presentation. Just one thing that you took away. Mine is, in peace times, we use SBCC models to sustain behavior change, and during outbreaks, we use the RCCE model. So let's have one key takeaway that you took from that presentation and from the Q&A and from everything that Padamoyo has said in the chat, and we'll be going through to see if we need to provide any more clarification to some of these things. Next, I'm going to be calling Yves Stefan from also IFRC African region, and he will be talking about the role of RCCE and community feedback mechanisms in pandemic and epidemic response, including integrated immunization programs. This is going to be a very brief presentation, so over to you, Yves Stefan.
Thank you very much, Malachi. Please, can you confirm that you can hear me very well and see my screen?
Yes, we can hear you and we can see your screen.
Okay, amazing. So yeah, I am Yves Stefan Galu. I'm the regional coordinator for RICS communication and community engagement with the collective service. And yeah, as you said, the position is hosted by IFRC regional office. So yeah, RICS communication is, as we know, very important, and generally it helps us to pay attention to how community is defined and how they are presented. It also helps us to be aware of the community perceptions, the beliefs, the questions, suggestions, and also their recommendations. And this is very important when we engage community members from the start of every action we are carrying out. And it helps us to understand what are the communication channels, and also, which is most important, trusted communication channels in the community. And these also help us to ensure effective coordination between stakeholders, taking into consideration community-based organization, civil society organization, faith groups, religious groups, etc. And also, it also helps us to provide feedback and explain to community health workers, to volunteers, and also to community members about what we are doing, our programs, our action, etc. So risk communication and community engagement is very important, especially to understand and to address vaccine hesitancy whenever we are intervening in a community. So when we talk about vaccine hesitancy, we have to look on the main factors like myths or disinformation, and these can really impact people's attitude, beliefs, knowledge, and intention to take the vaccine. And it can also target some specific group of people, and it's also a motivation for people affected by the perception. And we also have social influence that we need to take into consideration, which I believe about what others in the social groups in the community do approve or disapprove when it comes to vaccine intakes, etc. So, including and risk communication and community engagement is very important because it helps us to build trust and increase vaccine uptake whenever we and in a community. This by providing actionable and timely information for the different group of people, taking into consideration their different communication channels, and it also helps us to listen and to respond to the various people. And this is something we really put in front during COVID-19 vaccination. It also helped like support community-led solution, helping community members to be collaborators, to be the people leading the action into our communities. And for us to effectively carry out risk communication and community engagement, we need to listen. And listening to community members is also by putting in front what we call the community feedback. And the question is, what is community feedback? When we talk about community feedback, is everything that comes from the community. This can be questions, this can be requests, suggestions, this can be observations, this can be their belief or their perception. This can also be reports of concerns. This can be
I think we lost Eves for a bit. Eves Stefan, are you still with us?
we need to analyze this information.
Eves, we
To me?
lost you for a bit. We lost you for a bit. I think you have
Are you
some
getting me?
internet challenges. Yes, now we can hear you.
Is it okay now?
Yes.
Okay, great. Yeah, so I was saying that community feedback mechanism help us to collect data from community members, help us to analyze, refer this data, help us to understand what community members are saying and take action to respond to what very important, especially in public health outbreak. It helps us to ensure the right topic are communicated to community members. Hello, please. Please. Yeah, it helps us to communicate, help us to improve the quality of our program. It helps us to address problems before they escalate, and it helps us to also easily or rapidly identify sexual exploitation, abuse, and also corruption in our programs. And it helps us to really avoid wasting time and resources to leverage on the existing resources among all the partners. And also, it helps us to really touch the right people with the needed information. So why do we need mechanism? As I said, these help us to improve the quality and also the impact of our work, our program. It helps us to monitor our performance, listen and act on what the community members are saying in order to create trust in the community. It helps us to address and concerns before they are escalated. Ways for community members to report cases of corruption, of exploitation and abuse, and it gives volunteers and community health workers some way to refer difficult questions than from there to try to respond to questions that they don't have the information at that moment. And people have a right to complain, and we have a response to these people. How do we set up a community feedback mechanism? For us to set up an effective community feedback mechanism, we need to get buy-in. If it is a national feedback mechanism, if it is within our organization.
Yves, I think we lost you again. It seems like an internet issue. Stefan, with us? Okay, colleagues, I think we lost Yves for a few seconds. And while we're waiting for him to
Hello,
come
you
back
getting me?
on.
Oh, sorry,
Yes, Yves,
connection is
we
bad.
lost
Yeah,
you for a bit. Yeah, probably you
uh,
need to turn off your
switch.
camera.
Yeah,
Maybe
let
it
me
would
switch off the
support
camera.
your internet so that we can have a smoother run of the presentation.
Yeah, great. Yeah, so I was talking about setting up community feedback mechanism. So I was saying we need a buy-in. If it's a national feedback mechanism, we need a buy-in from the government. If it is within our organization, we need a buy-in from the management of the organization. We need to determine what is the scale of our feedback mechanism. We need to determine the communication channels, determine how we are going to document and share the community feedback mechanism. We need to map out and design the information flow of our community feedback mechanism. We need to agree on the roles, the responsibility, and the time frame of our community feedback mechanism. And we need to also identify the resources that we are going to need to run this community feedback mechanism. We need to make sure staffs, volunteers, community health workers are well trained, are well briefed on the community feedback mechanism. And we need to communicate widely on the existence of this community feedback mechanism so the community members are aware of the community feedback mechanism, and also we need to involve them. This is an example of a documentation of community feedback mechanism that we did in South Sudan. You can see how we disaggregated the data by sex, by gender, by channel, by type of feedback. And we also went into the state and also deeply into the different counties that we have, and also the categories of feedback mechanism, and also the term of the different feedback that we can receive. And we also make sure that we have the possibility to filter if we want to understand the information based on the type of feedback, based on the diversity factors, based on the language, based on the gender. So we need to discuss community feedback mechanism. And how do we need to do this? Internally, we need to make sure community feedback mechanism is at the agenda of every meeting. Community feedback mechanism needs to be an element that help to take decision internally. And externally, we need to make sure we have regularly interagency meeting, we have technical group meetings where community feedback mechanism is at the center of the discussion as well, and helps to take decision, helps to shape our program. And in community, we need to discuss with community representative, we need to discuss with all the different groups within the community. And as I said, sharing community feedback mechanism, we need to take into consideration the fact that when we share it, this build trust within the community and people start trusting the data. We need to analyze the key strengths and also the different topics. What are the most common topic raised? What are the different groups? What are the different channels and locations that we are using or we are receiving this community feedback mechanism? We need to also understand the time we need to respond to the community feedback mechanism. And when we are sharing community feedback mechanism, we need to understand that when we put quote from community members, it also helps to empower this community feedback mechanism. And we also need to provide some recommendation for people to be able to act on the community feedback mechanism. And if we have taken action, we need to talk about the actions that we have taken. And these are some tools we can use for us to be able to put in place an effective community feedback mechanism. This can be shared with you people later. Yeah, so in summary, we need to listen and act on community feedback. We need to make sure we have a good community feedback mechanism. We need to make sure that community feedback mechanism is at the center of the readjusting the decision making. We need to make sure that we share with all the different stakeholders the recommendations we have taken on the regarding the community feedback we have received. And we also need to make sure we close the loop. Comoros will go into detail and present how we have been using community feedback into their response in Comoros. So right now, je vais faire appel à Iliassa qui va nous faire une présentation sur comment
We have Diasa who shall
le
present
feedback communautaire
from
ont
Comoro
été
the community
identifiés, ont
feedback
été pris en
which were
considération pour
involved,
la
which were taken
réponse
into consideration
choléra au niveau de
to
Comores.
answer
Ilias, si tu es là,
the cholera
on va
epidemic in Comoro.
avancer.
So thank you so much for the floor.
Et merci beaucoup et bonjour à toutes
Thank
et
you
à
so
tous,
much and
effectivement.
hello everyone.
C'est un honneur pour nous
It's a
partager
honor
avec
for
vous
us to
notre
share with you
expérience en ce qui
our
concerne les mesures
experience
d'information
concerning
communautaire.
the
Bon,
community feedback.
tout d'abord, on doit
First of all,
nous présenter. Il s'agit de
our
l'équipe
presentation
d'environnement communautaire du Croissant-Rouge
is
comorien, vous
about
savez,
the
HMRC.
team from
En ce
the
qui concerne
Red
le programme,
Crescent from
on va tout
Comoro.
d'abord
For
commencer
the
par
program,
le
first of all, we
contexte
shall talk to you
de
about
l'intervention.
the
On
context
va
of the
aussi
intervention.
vous donner
Shall
le
also
rôle qui a dû
talk
être
about the role
communautaire dans la réponse,
that the
mais aussi
feedback
vous présenter
community
les méthodes
played.
qu'on a
Shall
utilisées
also
pour
tell you about the
collecter
methods that
ces
we used
informations
to collect
et les
these
réponses
feedbacks,
apportées grâce
and also
au
the answers
feedback
that were
communautaire,
given thanks to
donner
the community
quelques
feedback.
résultats
Then we
observés
shall
après
also share
l'intervention
with you
et
the
enfin
results after the
conclure par
intervention.
des
And to finish, we
recommandations
shall talk about the
pour
recommendations
pérenniser le système
to actually
d'information dans
make
le
this
collectif
system
du programme.
sustainable for
En ce qui
information on
concerne
the
le
whole
contexte de
program.
l'hésitation vaccinale,
For the
c'est
context,
manifestait sur
the
plusieurs formes,
hesitancy
notamment
about
la peur
vaccine
liée aux
showed
effets
itself
secondaires
in several ways. We
subis et
have
des
the
questions de user
side
experience dépendant,
effects that
méfiance
was
envers
mentioned.
l'origine du vaccin,
This was the question about
réticence
mistrust on the
en
origin of the
localité,
vaccine, and
notamment des
also some people who
districts
were refusing in
précis
certain
tels que
districts,
Sendai, par exemple,
like
propagation,
Sendeu,
sinon propagation
uh,
des rumeurs dans les
also
différents
some
districts.
rumors that were
Ces
circulating in
comportements
different districts.
menaçaient
These
directement
behaviors were
l'efficacité de
actually
la
threatening
campagne
the
de
efficiency
vaccination.
of the vaccination campaigns. To
Des
give
renforts en ce qui concerne les méthodes
more
d'intervention
support for
et
the
d'ajuster
teams
tout
that were
d'abord les
intervening.
stratégies de
So we
communication
were forced to
face
adapt our strategies for
aux réponses
communication
qu'on a reçues.
according to the response that we received.
Concernant les
So
méthodes, plusieurs
about
méthodes ont
the
été
methods that we
utilisées
used,
pour
there are several that
collecter
we
ces
used
retours
to
d'information.
collect this
Nous avons aussi, une fois formé
information
des
feedback.
volontaires au niveau
We trained some
des îles
volunteers
Brésil. Nous
on
avons
the
aussi
three
organisé
islands.
des
We also
émissions
organized, we
presque
came up with
200
radio
254
programs,
émissions radio ont
uh,
été
almost
organisées
254 programs
au
that
niveau
were
communautaire.
organized on the
Nous avons
community level.
aussi organisé
We
des
also
activités de
organized
cinématique
activities
aussi
for
pour toucher le
cinemas, out of
maximum
films,
des étudiants,
to
surtout ça a été
actually
en milieu
sensitize a
scolaire, mais
maximum of
aussi dans
people
les quartiers
in
vulnérables.
estates,
On
in the
a aussi
communities
mené
also.
des activités
We also organized
de
activities
sensibilisation, sinon
of
des visites à
awareness,
domicile, aussi
and also we
des
made home
activités
visits
de
and also
sensibilisation
activities of
aux parents.
sensitization by
et
using
des affiches ont été aussi
speakers, and we
adaptées et
also
distribuées.
used posters and which were adapted and
Aussi,
which
parmi
were
les
distributed.
activités que nous
And
avons
among
mises en
activities
place,
that we put
les
in
lignes
place,
téléphoniques, sinon les
we
réseaux
had also
sociaux
telephone lines,
mis
and
en ligne,
also
les
we
groupes
used social
WhatsApp.
media,
On a
and we also
partagé
had a
des
WhatsApp
informations
group,
à
and we
travers
shared
ces groupes et
information
des messages,
through those
mais
groups
aussi des
and
appels
messages.
téléphoniques ont
And also we
été
made telephone
mis là
calls.
pour
They were actually
collecter et
used
retourner
to collect
donner
or to get
des retours
information feedback
d'informations communautaires.
from the communities.
Et une fois mis en place toutes ces
Once
méthodes et
these
stratégies,
places and
nous
strategies were
avons
put in place,
créé
we
un groupe, un comité
created
grec
a
composé
committee of the
d'équipes partenaires qui
RCCE,
étaient sur
which was
place,
composed of
notamment
all
il y a
uh,
UNICEF,
uh,
OMS, Médecins
partners
sans
like UNICEF,
frontières et
WHO,
Direction
MSF,
régionale de la santé
and also
pour
the
appuyer sinon faire le
BRS
suivi des
to
décisions qu'on a prises lors
support
de la discussion.
our
Nous avons
interventions
aussi
on the
mis en
decisions that
place
we
un
took during
bureau
our discussions.
d'information dans la
We had
localité de
also
Pagé
an office for
qui est
information
dédié
in
sur
the
la
Paje
sensibilisation,
locality.
notamment
It
sur
was
la
about
futilité et
awareness
l'immunité
on
du traitement de l'eau qui a été
the
mise en place
utility
dans la
of
localité.
treatment in
On
the
a
locality.
aussi
We
organisé des
also
émissions
organized
en
some
direct, en live sur
programs
Star FM, là où on était
live on
spécifique
Star FM,
pour
which were
répondre
specific
à des rumeurs,
to
notamment
respond
sur
to rumors,
les
especially
7 principes, le rumeur
on
qui a
that
véhiculé.
principle,
Et là, on a
which was
visé
being
surtout sur
circulated. And we
les 7
targeted
principes, notamment
the
le
seven
principe de
principles,
neutralité
the principle
et
of neutrality
indépendance. On
and
a
dependence.
fait aussi une sensibilisation dans ce
We
genre
carried out sensitization
sur
also,
le choléra
or
en
awareness on
général et
cholera
sur
in
l'UTI
general,
parce que ça a été
and
touché
also
dans le
UTE,
secteur. Et sur la
because
base
this
de
was
cette base
also
données
affecting the
statistique, la
sector.
cartographie
So we
des
had
zones les
also
plus touchées développées
we mapped
par
also the
UNICEF
areas that were
et
most
des rapports
affected by
de
MSF,
SPC.
which are developed by MSF,
Les actions
and we
suivantes
had also
consistent notamment
SBC
l'orientation des
reports.
messages sur la
Especially, we oriented
diarrhée. Certaines
messages on
communautés
the
ont
color of
dit
the
non, que ce n'est
diarrhea.
pas de la
Some
choléra,
communities
mais
said no,
plutôt
it's not
du
from
riz
cholera,
amarré qu'on a
but
avalé,
it was
qu'on a mangé.
from something
Donc,
that
on
we
est
had
obligé
eaten, and then we are
de
actually forced
donner des messages, adapter les
to
messages, orienter les
adapt
messages en faisant
messages
comparaison de l'eau
by
du
comparing
riz et de l'eau et du diarrhée,
water from
du choléra.
rice and water
Il y a
coming from
aussi
the
la production de
cholera,
messages
diarrhea from the
ciblés en
cholera.
langue locale, notamment
We
le shikimori,
also
pour répondre
formulated
directement aux rumeurs.
messages
Il y a
in the local
l'implication
language, especially in the
des
Shikomori
leaders
language.
religieux, notamment
We also
les
involved
muftis,
religious
pour
leaders,
véhiculer
especially the
les
muftis,
messages
to
des fêtes
actually
du
pass the
vendredi.
messages, especially
Orientation aussi,
during
ça nous
the
a
Friday
permis
prayers.
d'orienter les
So this allowed
sensibilisations
us
sur les
also
risques
to
liés à la consommation
sensitize people on
d'allimages
the
et de
risks
boissons contaminées
that
sur les
was
adaptations de la
related to the
stratégie de
consumption of
vaccination vers les équipements
drinks,
mobiles.
contaminated drinks, and
Il y
also
a
have
aussi
adapted strategies for
l'importance,
vaccines or
ça nous a
immunization.
permis
We also,
d'orienter
it
les
allowed us
horaires
also
de
to
travail parce
change
qu'il y
working
avait pas
hours
mal de personnes qui
because
jeûnaient
there
dans
were
la journée,
people
mais aussi
who were fasting during the day
qui retournent tardivement
and people who were working
dans
late.
leur ménage. On était obligé à travers ces retours d'informations
So
d'orienter,
we
d'organiser les
also
heures pour
decided to change our working hours or our schedules.
les attraper. Et une fois mise en place, on a eu
And once we put this in
les
place,
résultats suivants.
we had the following
Hausse de
results.
la fréquentation des
There was
sites
an
de
increase of the
vaccination dans plusieurs
people who were
villages.
going
Au
more
début, ça a
to
été refus, mais
vaccination
après, on a vu la
centers.
fréquentation.
Uh,
Diminution des rumeurs dans les zones
so
fortement sensibilisées
rumors
ont
decreased
été
actually in the
éliminés
regions where we
négatifs.
had a
Au
lot of
final, ça
sensitization.
devient des
And
éloges.
finally,
Davantage
these
d'adhésion
turned out to be praises.
volontaire plutôt que
And we had more
d'acceptation
adherence
passive.
of
Le
people who were
climat de
accepting
confiance a renforcé qui
and also
facilitait aussi
have
les autres
trust that
volets de
was
la
strengthened
riposte, notamment sur les
when it
sites
comes to
appuyés
the
et toutes
response,
les équipes qui
especially
étaient
on
sur terrain.
30 and all
Alors
the
qu'au début,
teams that were on the ground.
c'était pas le cas.
And at
C'était
the beginning, it was not the case,
plus
actually.
difficile. Ils
It
étaient
was really
obligés
difficult for us
au niveau communautaire.
at the community level.
Suivant. pour pérenniser le système au niveau
So to
communautaire,
make this
toujours
system
au niveau
sustainable
national,
on the community level
nous recommandons
or on the national level,
renforcer les
we are
capacités des points
recommending
focaux,
to the capacity building of the focal points.
notamment donner des opportunités
Especially,
de
we should give
formation et
opportunities for
d'accompagnement
training
aux
and
nouveaux
also
entrants
for
techniques,
support to the
enseignants et
focal
feedback
points
pour
in the
améliorer la qualité de la collecte,
CEA
de
and also
l'analyse et de
to
la réponse au retour
improve
d'évaluation communautaire. Nous recommandons
to
aussi
the responses in the
échange
community.
d'expérience et
So
capitalisation,
we
c'est-à-dire
should
organiser
concentrate
des stages ou des
with
échanges
exchange
avec des
visits with
sociétés
national societies
nationales
which are more
plus
experimented,
expérimentées
and
pour tirer
also
parti de la gestion simultanée
leverage
des
on
propres projets pour
simultaneous
favoriser le
management
partage et
so that we
l'apprentissage
might share information and
entre
also we
équipes.
shall learn between different
Donc,
teams.
pour finir, là, je
So
remercie,
to finish, I'd like to thank
la Société nationale, l'ensemble des
the National
volontaires
Society,
et vous, en
all
tant
the
que partenaires
volunteers,
et leaders
and you
communautaires
as partners
qui
and
ont
also community
participé
leaders
activement
who
à
participated
cette
actively
dynamique.
in
Un grand
this
merci
dynamism.
à la
And I'd
Fédération
like
pour
to
son
thank
soutien
also the
permanent,
Federation
sa
for their technical
disponibilité et
support and
son
constant
engagement à nos
support,
côtés.
for their
Votre
availability and their
accompagnement est
commitment
essentiel pour renforcer nos
to
capacités
us,
sur le terrain et
and also their
améliorer
commitment,
notre
their
réponse
commitment to
communautaire.
our capacity
Merci
build and help
beaucoup.
us to respond
Merci
to all
beaucoup,
this. Thank you
Ilyasa.
so
Thank you very
much.
much, Ilyasa. So we keep in mind that
Mm.
community feedback help Comoros to adapt their messages, to do production of message in local language, and also to engage with religious leaders, and also to adapt the vaccination strategy and also the vaccination time. Finally, to reinforce communication in high-risk area. So thank you very much for your participation. Amalashi, over to you.
Thank you so much, Yves and Monsieur Ileasa. Thank you for that very elaborate presentation. We are quickly going to have two polls from the last two sessions that we didn't do initially. Colleagues, this is to encourage, engagement with you, and so that we know what more to address or if we haven't addressed something. So, Aditi, may we have the polls up? While the polls are coming up, colleagues, may I encourage that we take our questions to the Q&A and not the chat. The chat is so full with a lot of information. We may just miss out on your questions. Please move them to the Q&A. May we have the polls up now? Absolutely, colleagues, we have a poll up on the screen. Please take some time. We have about 5 minutes for this to tell us what your opinion is. I think the question is, which of the following are factors of vaccine hesitancy? Yes. We have about 6 responses now. Let's keep it coming. While that is going on, may I take the time to acknowledge the colleagues who have joined us in the last 30 minutes of the presentation. To the IT team, Tiho Mole is not able to see the polls. Maybe we can support him with sending him the link to to his chat on the Zoom platform, but the polls are up and we're receiving a lot of responses. I apologize that you cannot see them. We have 1 more minute for this poll and then we move on to the next poll. All right, next question. Great. So the next question we have is, which of the following best describes the role? Colleagues, if you can see the poll, please react with a thumbs up so that we know that you can see it. We're beginning to receive some responses already. Thank you so much. Which of the following best describes the role of RCCE in epidemic or pandemic preparedness? And the second question there would be, Why is it important to have a community feedback mechanism in an emergency response and vaccine rollout strategy? We have received 7 responses for that, and we've received about 13 for question 1. Let's keep the responses coming in. We have about 2 more minutes to do this, and then we can move forward. Why is it important to have a community feedback mechanism in an emergency response and vaccine rollout strategies? Okay, colleagues, we have 1 minute, and then we can move forward. Okay, may we now share the results of this poll? May we share the results of the poll? Panelists, I hope you're looking at the poll results so that it can also inform some of the discussions that we're about to have with the panelists. And for the previous poll, may we also have the results pulled up? For the previous poll, yes, may we have the results pulled up? Yes, exactly. Great. Thank you so much, colleagues, for participating in these polls. It helps us to know that you are there and you are following the conversation. We're going to move on now to the interactive Q&A session with the panel. And on the panel, we have everybody who is here. We have Yves Stefan, we have Daniel Dormersan, we have Kobe Aminata, we have Monsieur Ilasa, if you need more context to what Comoros did. We have Paida Moyo Magaya from Africa CDC. And we're also hoping that Kakule Deogracias is able to support us. I know that he's really busy in another meeting and he's multitasking at the moment. So, colleagues, I would like to invite all of us to raise our hands for the questions. If you want to have questions, just raise your hands, use the raise hand feature, and I'll invite you to speak and we'll have the panelists respond to you. So I'm looking now in the participant, among the participants. Please raise your hands if you have any concerns or questions for the panelists based on any of the presentations, and we're happy to take your question. While we're waiting for colleagues to raise their hands, I'm going to start with a question, some of the questions in the Q&A. Is Philip Ngere wanted you to speak to the role of governance in worsening hesitancy, and how can this be addressed?
Okay, Malachi, thank you very much. And thank you, Philip, for this wonderful question. And yeah, governance play a critical and often underestimated role, especially when it comes to worsening hesitancy, and particularly in areas like public health. And we have seen this most of the time in vaccine hesitancies. So this is largely caused because governance directly impact trust. This is something we need to keep in mind. So how do they really worsen, like let's say, the vaccine hesitancy? Through lack of transparency and lack of open communication. If the governance doesn't portray transparency, doesn't communicate openly, this can really worsen the situation. If they perceive corruption and there is mismanagement that can be seen by everyone, this can also be a source of worsening the situation. And also there is erosion of trust in the institution. They are like the main people handling the institution. So if there is like mistrust in the institution, in the organization, this can also be a factor. And we have governance people from the governance who are authoritarian, who use coercive approach to do management. And we all know this is not good because it can lead to mistrust. And we also have, let's say, a historical mistrust and mismarginalization. This is also something that can impact the organization. And it's very important if we want to address all these elements. One, to enhance transparency and open communication whenever there is outbreak. We need to be very clear on our communication. We need to be very concise on our communication. We need to strengthen accountability and also within the organization, we need to combat corruption. We need to make sure that we have rebuilt trust in institution and also in expert. And that is why whenever there is an outbreak, we bring in experts because they are the one to handle it. For instance, if we have an expert on public health and we need to communicate on issues related to public health, we need to make sure we provide the necessary resources and opportunity to this expert to be the one to address this public health issue. And we need to foster community engagement and participation. Governance are the one to take the measured decisions, and they need to make sure that community engagement and accountability, community participation is within the program, is like the DNA of the operation or the program that we are implementing. And they need to make sure to combat misinformation and disinformation. They are the one doing regularly press conference. They need to consult the expert to understand what are the feedback saying? What are the recommendations they can use during this press conference to combat misinformation and disinformation? So these are some elements I can provide. Maybe other panelists or other experts in the team can also come on to provide more information. Thank you very much.
All right. Thank you so much, Eves. I'm wondering if any of the colleagues want to add on to how governance affects hesitancy. If not, then we move on. I can see that Pada Moyo is responding to a question, so I'm going to skip that. Colleagues, may I encourage that we use the raise hand feature and so that we can ask our questions and interact with the panelists live. And while we're waiting for you to do that, I'm going to move on to a question by Masego Champion. I'm pretty sure that Aminata already addressed this, but I'm going to ask it again so that Aminata has the opportunity to do it again. Masego is asking if there is a standardized reporting, either a format or a system for RCCE from the national to the regional level.
Yeah,
Thank
so
you
I
very
would take
much.
that in. Okay, Amina.
As I said earlier in the Q&A session, there are guidances that have been provided globally on reporting. However, each country has to adapt the reporting system. But I also emphasize the importance of reporting, especially for risk communication and community engagement. As risk communicators and community engagement people, we do a lot in the communities and in the field. However, we have challenges documenting these to show that behaviors are being changed and we are communicating in a credible way to communities. So each country needs to have a way of reporting, not only from sub-national levels to national levels, but also at national level to be able to document that we are empowering people to change and to break chains of infection and to protect themselves. We really need to document this, that what we are doing is working. And if it's not working, we also need to document what we are doing to improve the situation. So not documenting alone is a weakness in our area of work. Over.
Absolutely. Eves was also going to add on to that. So over to you, Eves. Thank you, Aminata.
Yeah, so I think Aminata said it all. There are guidelines that help to develop report, but we need to understand that based on the context of the country, we need to adapt on this report. So basically, what we need to highlight when it comes to risk communication and community engagement report, especially when it comes to community feedback report, one, we need to highlight, analyze the key trends and also topics That is, what are the most common topic raised? What are the difference across the groups, the channels, the location, and yeah, we need to also provide what are the changes over the time. We need to, as I earlier said in my presentation, if we can highlight some of this code, this can like bring more light on your report, and we need to make sure that we provide recommendations. And in the report, if there is a possibility, we can also provide actions taken to address previous recommendation. So these are elements we can take into consideration in the report. But as Aminata said, we need to adapt based on the country need. Thank you.
Thank you so much, Ish. That was very, very informative and concise. Um, for our colleagues who ask questions in French, I'm talking about Debon, Eunice, and Ndumi Constant. I'll be handing those over to Danielle to manage. As you can tell, I don't necessarily speak French. I've been jumping over them, but I'm just going to ask a last question for the colleagues to respond to, and I'm going to be handing these over also to Aminata and also to Eves. Um, Moyo is here, but yes, and I also think that Moyo is gonna have some input into this particular question. Oliver Ja from Monrovia is highlighting some of the issues that we had during the COVID-19 response. And he's saying that during political campaigns or elections, some politicians, in a lot of instances, provided information that are counterproductive or that were counterproductive of RCCE. Some of them were misinformation, some of them were rumors, and all of that. And in that instance, a politician's actions undermines vaccine rollout efforts, leading to a high level of hesitancy. What practical approach would we recommend uh, to manage this kind of situation? I'm going to start with Eves, and then I'm going to move on to Laida Moyo, and we can see if they don't cover everything, then Aminata is going to jump in. So over to you, Eves.
Yeah, can you read the question again, please?
Asking, he's saying, he's highlighting the COVID-19 response, and he's saying that in that instance, political campaigns and elections, in the instance of political campaigns and elections, a lot of politicians provided information that were counterproductive to RCCE efforts during the COVID-19 response. And in that instance, a lot of their actions undermined vaccine rollout efforts, leading to a high level of hesitancy when we were trying to convince the public to get vaccinated against the COVID-19. So he's asking, what practical approach would you recommend to manage this kind of situation?
Okay, yeah. I think that's a very interesting question, especially when we are faced with influencers, people with high influence sharing misinformation. And one of the things I would suggest to do is also to approach these people, try to build their capacity, try to make them to understand what are the actions we are taking, and provide them with re-information, provide them with timely information. Another action we can do is, because obviously the misinformation they're sharing create more misinformation in the community. So putting in place a solid feedback mechanism to be able to listen to what other people are saying based on that feedback will help us to respond to this feedback on time and to be able to address this and to counter the, let's say, the escalation of this feedback. Yeah, thank you.
Thank you, Eves. Eves has just provided a response from the RCCE point of view during the response. I'd like Paida Moya to jump onto this because she had presented something on the behavior theories and how to counter hesitancy for sustained behavior from the SBCC approach during peace times. Paida Moya, how would you want to respond to this?
Okay, thank you so much. So just to add on to what Uvesi already mentioned, I think when such situations happen, it is always critical to first engage the such political leaders behind closed doors and use some credible messengers within their circles that can help counter the messages, that can help build the trust that can then counter the misinformation. Another way we could solve this issue is to maybe come up with a campaign, identify some vaccine brand ambassadors that are very powerful in their opinion leaders that can be listened to by the communities, and these will help to neutralize the misinformation. And also, because we are creating messages, let's find out the source of this misinformation. Let us find out why these policy makers sending bad messages, and then if there's need, we then need to reframe our messaging so that we continue to create trust among the communities. We continue to create trust even among the voters. Thank you.
Thank you, Paidamoya. That was very helpful. Just before I hand over to Danielle to manage our French questions, there's a follow-up question that we have about what other factors negatively impact trust aside from governance. A colleague of ours asked about how governance impacts trust and hesitancy. Are there other factors that negatively impact trust and hesitancy that we need to highlight in this session? I'm going to start with Paida Moya, and then I'm going to have Danielle on this one too. Paida Moya, over to you. Paida Moya, if you're speaking, you're muted. Okay, Aminata, do you want to jump in before Danielle
Yes,
goes?
I think maybe we'll do a session where we'll talk about trust, which is critical for its communication and community engagement. And one of the issues that influences trust is announcing early to the community what is happening. So sometimes we take a lot of time to confirm the outbreak, and by the time we announce to the community, they already know what is happening. So it affects trust a lot. And also having a two-way discussion with the community, always giving them update of what is happening is critical to ensure that trust is built. So announcing early what is happening and also updating the community with information also helps to improve trust. Over.
Thank you so much, Aminata. Danielle, do you want to add into that?
Yeah, Maharaj, I think really a lot of the key points raised be really addressing the negatives. Well, the contrary to what was mentioned in terms of best practice, really a coordinated, having a lack of coherent messaging, having a lack of or having contradictory different sources. And I believe it was Dr. Kobe that mentioned having coordinated approach and having partners, having clarity in messaging. And that when you have multiple sources of authorities and influence giving contradictory messages, and also in response, not having a proactive response, not monitoring what is being said, behavior and practice are influenced on the day-to-day. So not having a proactive ear listening and having that feedback, then you're very late in responding. But I heard of key speakers have really tied into what are the best practice and how then us to address the reverse of that and looking at multiple aspects from environmental these social aspects, social networks, all of that ties into impacting positively trust and addressing hesitancy. Would you delve into the French question as well? So we had a
In a
few
minute.
questions. Yes.
In a minute, Daniel. We have Deo here, Deo Gracious Kakuli, who would like to add on to the conversation about politicians providing counterproductive information to RCCE efforts. Colleagues, if you remember, I had said that Deo Gracious has been on the ground in a lot of the emergencies, responding, providing RCCE efforts in all of these responses in COVID, in Mpox, in cholera, in most of the countries. He's able to give you contextualized information about how this was managed. So, dear gracious, welcome. The question is that during political campaigns or elections, politicians in most instances provide information that are counterproductive to RCCE efforts. In an instance where a politician's actions undermines vaccine rollout efforts, leading to high level of hesitancy, what practical approach would you recommend?
Yeah, so thank you very much. And also thanks to all the panelists for the great responses that have been already provided. So I would practically say that building on what we did during COVID, and that happened in several countries all over Africa, I can remember that what worked very well was to assess the situation and see the receptivity from the politician. Is this someone with whom we can directly engage in terms of an advocacy meeting, to utilize the same channel from his neighborhood, from the people who believe in him, and from the influencers, to sort of influence positively and correct indirectly what he has been saying. We use such practices, and it's worked in some countries where we utilized the same politician to correct the information, even to get the engagement from the same people to get vaccinated publicly. And that happened during the vaccination campaigns, utilizing the electoral opportunities. And what I will tell you, electoral activities are a very great window of
الجهود
opportunity for us as RCC to improve on acceptance on public health measures using the politician. And this is a period when people are gathering and people are hearing a lot, and the presence on the social media or the media is very high on that time. You can even use other social channels like churches and public markets. It works very well. You still need to do a very quick assessment and know whether it's possible to utilize the same channel, or you can use another channel around the communities that have been the most affected by the negative influence. That's what I can say. Over, and thanks.
Thank you so much, Dio. I think you also captured what the other panelists had said initially. Thank you so much for providing some context to what you did in some of the communities during the COVID-19 response. I'm now going to hand over to Danielle to manage the French questions. Danielle, I'd advise that we have Deo here for a few minutes. Maybe he will be able to answer some of the questions before we move on to the closing. Over to you, Danielle.
I'll actually see both questions. I'll put both questions together. They are quite similar, and I'll start maybe with Eve, but also the panel can also chime in. It's around feedback mechanisms per se. So what are the basically asking a bit more examples on how to roll out the feedback mechanism at community level? Does it depend on the specific type of outbreak or the hazard that we're a best strategy to capture community feedback mechanisms, especially around vaccine centers? So those two questions intertwine. Eve, that spoke heavily mechanisms. Do you want to take this one as well? Over to you, Eve, and colleagues.
Okay, Daniel, thank you very much for that. Let me open again the question because your connection didn't permit me to get it very well. Okay, yeah, the question, the person is asking if the sharing of community feedback mechanism depends on epidemics ou la crise or the crisis. Okay, yeah, so I think community feedback mechanism, generally we have a guideline to put in place community feedback mechanism. But before we put in place this community feedback mechanism, there are research we need to carry out to understand what is the power dynamic, what are the community communication channels, what are the preferred communication channels. And from this, we'll be able to define how to collect information from community members and how to share information. And once we have understood what the power dynamic, especially the different groups in the community, I will take an example in Equatorial Guinea. When we're working, we noticed that traditional healers are best placed to share information to communities because they believe more to these traditional healers. So we engage them, we reinforce their capacities, share with them verify and trustworthy information, and they were the ones sharing this information to community members who are coming towards them to get information about this. So yeah, it's very important to understand what is the best communication channel we can use to be able to share this information. Thank you.
Danielle, are
Thank
you back?
you.
Can you?
Yes,
Great.
there's one question around specific strategies to address hesitancy, the last one in French, but that one actually gives me the opportunity to invite you to our next session where we will look at evidence-based RCCE strategies that will delve more into the how to then address hesitancy and trust and roll out RCCE programming. Amarachi?
Okay, thank you, Danielle. Colleagues, we have come to the end of the Q&A. Unfortunately, we did not see any hands, so we'll be made clear with the questions that you had given us in the Q&A session of the Zoom platform. And thank you so much for engaging in this conversation. I'm now going to hand over to Danielle to do the summary and the closing. And colleagues, may I request for an extra 5 minutes for us to do this, and then we can close the session for today. Thank you so much for staying with us. Over to you, Danielle.
Thank you very much, Amarachi, and thank you to our speakers and to our technical teams and interpreters for the support today. It has been an insightful session, and your participation and insightful question helped to move forward with this interesting conversation around risk communication, community engagement in epidemic preparedness, response, and recovery, and that also includes the vaccine uptake or immunization programming. And all our speakers around that topic really had a similarities in terms of the key messages and key takeaways, and really starting with understanding, knowing your communities through evidence, through data, through information and feedback mechanisms as proven key piece as a starting point is to contextualize and address and build your strategies and your system and inform decision making. We also learned that trust is something that you build, that you sustain, and that you continue to fit into through accountability, to proactive communication, and that's an entire process. And we've seen how then you build between RCCE programming and longer term sustainable social behavioral change programs as well. All of our speakers in a way or form have mentioned the dynamic aspects of RCCE and social behavioral change, having a very multi-approach, multi-tools, multi-channel approaches to RCC and social behavioral change based on your target groups, based on the evidence that is conducive to getting the results we want, which are healthy behaviors and avoiding the risky ones. Other key takeaway message would be around coordination. All our speakers and proof here of all our platforms and partners here and in the call as well, looking at how important it is to have a coordinated approach either at local level, national level, multi-country or continental or region or continental level are all important. And that's a key piece of RCCE. RCCE is not a silo. Information flows very quickly at multiple levels. So we have to be proactive. And again, going beyond information sharing, RCCE goes beyond information sharing alone. We need to keep and maintain those two-way communication mechanisms and having the communities as key actors, not beneficiaries, not recipients, not passive, but really key actors. And that's our key takeaway from today. Thank you again, and back over to you, Amarachi.
Thank you so much, Danielle, for that summary. Colleagues, thank you so much for joining us today for the first session in the series. We're going to have several sessions that come on after this, and a lot of them are going to address some of your questions and some of your concerns or your learning needs. So please bear with us. We'll also be sending out some invitations for the second session and also a calendar invitation. Please accept so that you have it in your calendar as a placeholder and you're reminded to join the session. Colleagues, I realized that we just introduced the IECO as our learning management platform. You can get the presentations and the recording at on the IECO platform. If you're having any difficulties finding them, please write me an email and then we can guide you accordingly. I see Tambe is asking if there will be certificate. Yes, Tambe, there will be an attestation of attendance at the end of the series. And we hope that you are able to attend all of the sessions. Colleagues, please also do us a very great favor to fill out the post-session survey and tell us all of your opinions. If there's anything that you'd like us to add or any learning concerns that you have, we're happy to accommodate that in the subsequent sessions. Please write it in the post-session survey, and then we can look at it and improve the session to your benefit. So thank you so much for joining us, colleagues. At the end of the session, we still have a large number of people that are still with us. Thank you so much for staying with us, and I hope to see you in the next session. Goodbye, everybody. Goodbye.
Goodbye, everyone.
مع السلامة.
Good. Thanks to our interpreters as well. I hope we didn't forget them. Thank you so much for your support today.
Thank you so much, our interpreters and our panelists who stayed with us till the end. All right. Thank you, colleagues. Goodbye.
Thanks, everyone.
Yes, Vashti, we're going to be sharing the presentations. They're going to be on the IECO platform. However, if you are having some difficulties finding them, write me an email and we can direct you and I can send it to you directly. Thank you so much, colleagues. All right, goodbye, everybody.